Welcome to our conversation about the public health crisis on the U.S.-Mexico border. My name is Stephanie Freithoff, and I'm an international journalist and the director of content at the Harvard Global Health Institute here. What brings us together here today, I think, is our shared concern for an estimated 60,000 migrants who are stranded at the Mexican border. People who are fleeing violence, abuse, persecution, gang wars, and other horrors in search of a safer and more productive and healthier life. And I think regardless of which party you vote for or which church you pray in, or if you don't pray at all, I think we're here together because we feel a shared sense of responsibility about what is happening to these people as they hit a dead end on their treacherous journey across the Americas. A little over 3 months ago, many of us met in a packed room here at Harvard to look at what was happening to migrants on the US side of the border. We heard from lawyers and social workers. We learned about the horrific conditions in the detention facilities in Texas and California, and of course about the family separations. Back at that event in July, we talked a lot about the importance of witnessing, because the abuses that were happening this summer on US soil and the abuses that are happening now on the Mexican side, they all thrive on silence. 3 months have passed. Things have changed significantly, and the lack of transparency again is staggering. Over in Tijuana and other communities, tens of thousands of people are stranded in towns so dangerous that the US government warns us not to travel there. Advisories say they are as bad as Afghanistan and Syria. This is where we're sending men, women, and children to await their asylum hearings. People are left in the streets, and in many places there's no shelter, no food, no water, no hygiene. No one is prepared to deal with this situation. And those migrants, they can't even work or do other things that, retain their resilience and provide for themselves. Plus, they have no way to protect themselves. I'll quote just one sobering statistic from Médecins Sans Frontières. Every second patient seen by MSF in recent weeks has been a victim of local violence in the city where they are staying. In other words, every second person who made it to the US border is now exposed to more of the violence that they have fled. So why is this happening? The Trump administration has made some quiet but consequential changes to the US asylum system over the past month, and layer by layer, a series of impediments in Central America at the border, in detention centers, and in the immigration courts have made obtaining asylum increasingly difficult. The consequences of this policy shift is that people who are fleeing violence are put in more violence and are pushed to take even bigger risks. It's not the action anyone envisioned this summer when the entire country balked at the bad conditions in detention centers here in the US. So today, we hope to shed light on how exactly these latest policies affect migrants and the communities that host them. I assure you, this will not be an ivory tower conversation. Today, we'll be able to engage with those who are working hard to witness and mitigate the crisis where it is unfolding on the front lines. You will hear from an emergency nurse and a shelter director, from a journalist who is covering the events on the ground. You will hear from researchers who have frontline experience, and advocates and international rescue organization leaders who have seen this devastating movie before. Today, we will witness powerful testimony and analysis, and we're all grateful to our speakers for taking the time to come here and tell us your stories, and to share evidence of how this is all playing out. We need to hear it. We need to help others hear it, because there's just too much we don't know and too much we can't do because we don't know. For example, who all is currently providing care to this stranded population? What is the role of the Mexican and international health institutions? With what physical and mental health needs are migrants presenting at shelters and care centers? And have these care profiles and needs changed as the policies have changed? How's the Mexican government responding, and what are local leaders doing? These are just some of the questions that we will ask today. We do so for many reasons, but let me just mention one really important one. The research on the long-term impact of this type of physical and psychological trauma is very clear. The less we support migrants today, the worse they will be off tomorrow, and the more work we will have in the future. This event has become possible because of a remarkable collaboration that unfolded after our July event. I can't tell you how uplifting it is to see such a productive and completely ego-free coalition unfold in such a short time. So let me make sure I mention all our major partners who are involved in this work and who have put tremendous amounts of planning and thought into today's event. So from Boston College School of Social Work, we have Alejandro Olayo Mendez and Thomas Crea. From the Woodrow Wilson Center, we have Rachel Schmidtke. From the David Rockefeller Center for Latin American Studies here at Harvard University, we've worked with many, but most importantly, Paola Ibarra Deschamps. And from the Harvard University Mexican Association of Students, especially Daniel Aldaco. And last but not least, the major driver of this event were both Megan Diamond from the Harvard Global Health Institute and Talia Porteni, who is currently doing a postdoc at Tufts University. Now, it's my great pleasure to introduce our keynote speaker to you. As we all know, these types of crises, they never happen in a vacuum. They're things that have come before, and there are histories and memories and policy that shape them. So to really understand and frame what we're seeing unfold, we were looking for a speaker who's deeply embedded in both the US and the Mexican context on migration, and also brings a health lens. We could not have found a better voice for us to frame this conversation today than Dr. Eduardo González. He's an assistant professor at the Mel and Enid Zuckerman College of Public Health at the University of Arizona in Phoenix. And he has worked for over 15 years on demography, and public health research in the US-Mexico border area. He has extensive experience surveying and working with Mexican immigrants as part of many binational health-related research projects. For example, he is part of a binational research team developing surveys focused on HIV risk and access to health services among Mexican migrants traveling through the north border of Mexico, including migrants returning to Mexico via deportation. Please join me in welcoming Eduardo González.
Building suspense. Yeah, I could just get
Thank you so much for your kind words. I lost you. I don't know where you are, but thank you. Thank you so much. Well, what I'm going to try to do today with you is to present a very broad review of the Mexican experience in regards to providing healthcare to migrants population, specifically Mexican migrants population here in the US, but also in the border on the Mexican side. So everybody, when we think about migration in the US, mainly we think about people coming from Mexico, which is true because we send approximately 11 million people. So it's a lot of people, and they have families in here, so we are talking about 25 million of Mexican American population here in the US. So it's a large number of people. But something happened in between 2010 and 2014 that Mexicans just stopped coming to the US in the largest amounts they used to do, unless until 2006, when we saw almost 1 million of Mexican migrants crossing the border to coming to the US. So starting there, the numbers start going down. And together with that, what happened is a lot of Mexican people here in the US start going back to Mexico for many reasons. They decide to retire in Mexico, they just were deported, or they consider that the economic situation here in the US wasn't the optimum they were trying to get, and then they just decide going back to Mexico. The combination of all these movements in the migration flows got as a result that we have now 11.2 million of Mexicans in the US, which represents a shrink from the last number I can remember was 11.6 Mexicans in the US. So we are talking about almost 400,000 reduction of Mexicans in this country. So this is I'm pretty sure you can see the numbers. It's the trend of the deportations to Mexico. As you can see, in 1997, 98, it's a peak. Almost 1.2 million of Mexicans were deported to Mexico. And then the deportations start going down and down and down. So this reduction we have been talking about, it's mainly because Mexicans in the US, they just decided to go back to their country. And as we can see, the number is falling down, and it's like nothing's going to happen in a different way in the coming future. Okay, so we have all these people in the US. They are working. We know where they work. They work in the landscaping, in the construction, services, cooking, driving Uber. But what's the reason they are not doing really well here in the US? We know all the research has been done in the past that the Mexican migrants, they don't have the better socioeconomic conditions compared with other immigrants and compared with the native-born population. They have many really bad conditions. They even are in poverty conditions. They have no access to health care. Their income is pretty low. So the lack of access to health insurance maybe is one of the most clear indicators of the struggling for this population here in the US. That combined with the fact that we, the Mexicans, we don't like to go to see the doctor because everything's gonna be fine. Yeah, I am in pain right now, but tomorrow not, and maybe I'm gonna have this little tea, or I'm gonna take some pills from my town, so something like that. So like the idea in here is we don't have access to healthcare in the US. Almost 50% of Mexican immigrants in the US, they don't have access to healthcare. And those who has access, in many cases, they have this insurance that only cover emergencies, which basically doesn't cover anything, unless you are getting into the ER room with your guts in your hands, like, I believe I need some help. That's what I'm seeing right now in Arizona, where I live. People is not going to see a doctor, even they have this kind of coverage, because they know they're going to be paying $100, $200 every time. And maybe for some of us, that's not a lot of money, but for them, represents, in some cases, 50% of their monthly income. And they still have to pay rent, bills, food. So after a review of these socioeconomic conditions of the Mexican migrants, specifically the lack of healthcare access in the US, the Mexican government created this program called Ventanillas de Salud. The best translation we can find for this is Windows to Health. I don't like the translation, but this is the best. I don't know if you are familiar with this program. Okay, thank you. So this program was created back in 2003. It's basically it's a kiosk, like this table, in every single Mexican consulate in the US to provide very basic services to the Mexican community. These basic services are health screenings like glucose, blood pressure, BMI, but also a lot of information. If you ask a Mexican migrant on the street if they know where can they go to see a doctor for a medical check, they don't know. They only know that they can go to the ER if they are really in need of seeing a doctor in an emergency case. So the idea for the Ventanillas de Salud is to provide information where they can go. Many people are saying, I'm not going to see a doctor because then I'm going to be asked for an ID, and I don't have one. Or I have the matrícula consular that basically is a sign saying I am undocumented person. So they are avoiding to go to see a doctor. So the idea of this program is to let them know, no, you can go to a federally qualified health center. They are receiving some funding from the US government, yes, but by law, they are not allowed to request any ID other than matrícula consular or your Mexican passport, or even ID from, I don't know, from your work. And also the idea of this program is to provide health education. We strongly believe that education is the best way for empowering people, specifically in health. So this is where the Ventanillas de Salud are located. As you can see, a lot of them are in border cities with Mexico, because a lot of Mexicans live in there, close to the border. But even though they cannot cross back to Mexico, so they are staying there in the border. This is the kind of services the Ventanillas de Salud, VDS, are providing right now: immunizations, health education, information of health insurance options, health screenings, referrals to healthcare providers, and how to navigate the health system. For us living here in the US, we know how complicated it could be understanding the healthcare system. And you are moving from one state to another, it's a completely new world. I live in Arizona, but I used to live in Tijuana, and I'm still alive, by the way. So when you go to San Diego, the clinical facilities, the system is in a very different way than Arizona, and they are neighbors. And it's a completely new whole world. So for people who, in addition, they don't speak English, or they don't feel comfortable speaking English in health topics because they don't know how to say that they had a wound because of their work, or they have a pain, or they have a dizziness, or etc. So how this program operates, the BDS are operated by academic research institutes. institutions, community centers, clinics, hospitals, in general, non-profit organizations. And the Mexican government provides seed funding in an annual basis just to start working to provide the most necessary supplies for this program to run. Oh, by the way, those are the representatives from all the 50 ventanillas de salud. They had an annual meeting in Atlanta 2 years ago. Okay, I'm not gonna spend much time with this. This is how they work. Okay, based on the good experience of the ventanillas de salud, the U.S.-Mexico Border Health Commission, Mexican section, saw that many of the Mexicans are not going to the consulates. Who is going to the consulate? Those persons in need of a passport, a birth certificate, or to resolve any legal issues in Mexico like last wills or property selling, etc. So it's not maybe the better way to reach a large amount of population. So this program, the mobile health units, was created with the idea to be the outreach arm for the ventanillas de salud. That's I don't remember. I believe this is the one from Denver. So all the ventanillas, all the mobile health units look exactly the same. It's a big truck. And we drove this truck all around in 11 different cities across the US. Okay, there you go. So how was decided in which cities a mobile health unit will be? The decision was made based on the amount of Mexican population living in those areas and also the amount of people who actually is going to the consulates and the coverage area of these consulates. So for example, the Phoenix one covers from Phoenix to northern Arizona and a little part of South Utah. So it's a large area. So we are working with all this population. The idea of the mobile health units is exactly the same as the ventanillas de salud. Provide basic services to underserved, undercovered, underinsured populations in these specific areas, and also providing some screenings, basic screenings in those illnesses we identified are the most prevalent among the Mexican communities across the nation, which are basically diabetes, hypertension or heart diseases, and obesity and overweight. And also we provide a lot of health education and immunizations, which is not provided by us because we don't have the license to do that. That's another very good point in regards to this model. We work in collaboration with several partners. In my case, in Phoenix, we work with Walgreens, CVS, community clinics in Phoenix, and even small pharmacies. They are providing the immunizations for free for many reasons. Mostly because in Arizona, at least, I don't know if that's the same across the nation, the counties are the authorities that are distributing the immunizations. So at some point, they just decide to release all the inventory of immunizations. So they have a lot of stock, and they start doing those for free. Right now, we're doing flu and hepatitis A immunizations in Phoenix. Maybe you know that there was a big outbreak of hepatitis A in LA, and starts another one in San Diego. And the local authorities in Phoenix identified many cases of hepatitis A. And as you know, it's a very easy to transmit infectious disease. So we are working in that providing this service to the Mexican community mainly because they work in restaurants, they work in hotels, they work in many places that they are in contact with a lot of people, and they are being asked to get this immunization as a requirement for their job, and because they don't have any health insurance, they cannot afford $40 to pay for this vaccination. I remember this lady we were working with, providing these services in the mobile unit in Phoenix, and I asked her why she wasn't going to see her doctor. She is diabetic, she's not doing well, she's losing her vision, so she's basically blind. And she said, because I can afford the $2 to go to see the doctor to pay the bus. So it's only $2 that we use for, I don't know, we expend in anything else. These people are not able to pay even for the bus ticket. Okay, based in this model of ventanillas de salud and the mobile units, the U.S. Mexico Border Health Commission, Mexican section, created this other program to provide medical attention for the Mexican deported migrants just after they are released from the migratory authorities in the U.S. I don't know if some of you have been there in Tijuana, Nogales, in some of those deportation places. The nicest one is in Tijuana because it's pretty new, pretty well designed, but others, like the one in Nogales, is back from the 70s, I believe. So it's an old building. So the idea is to, just after they are, I don't know if that's the right word, to the U.S. authorities deliver these people to the Mexican authorities. They are having a lot of services because many of them have been out of the country like in the last 20 years, 10 years. They don't know what's the deal. They even know those cities because they cross the border through maybe Ciudad Juárez, El Paso, and they are now in Tijuana. And Tijuana has been growing really fast in the last 20 years. So the idea is to provide these services to this population because exactly the same reason we are doing these services in the ventanillas de salud and the mobile health units, because they haven't seen a doctor. Some of them, even when they crossed the border to the US 20 years ago, 10 years ago, that was the last time when they go to see a doctor. So it's a long time not seeing a doctor, so it's a good opportunity for us and for them to take care of their health. These clinics or these modules provide basically the same services. The difference here is we have MDs providing medical attention, and also we have psychologists because many of these people are struggling. They were detained on a light because they didn't have their seatbelt, and sometimes in a week they are out of the country and they didn't have the chance to see their families. They are just only communicating to them by phone. In other cases, they just had the time to say goodbye. So it's very, very complicated situations, and that's why we have the psychologists. They are providing this crisis intervention to stabilize these people, because sometimes, especially the women, if they left behind their children, they are doing really, really bad. So it's a good opportunity for us to help them to take a perspective, make smart decisions, try to make the wrong decisions, and try to think forward. These modules are located in 5 points of deportation. The first one was opened in 2012 in Tijuana, and then we opened another one in Matamoros in 2014. The next one was opened in Nuevo Laredo and Reynosa in 2016. In 2017, it was opened in Nogales, another one, and we are expecting to reopen the module in Mexicali into next year. And I'm saying reopen because it was open just after the one in Tijuana, but somebody decided to take all the stuff away. So we decided not to keep open that module because the safety condition wasn't the most appropriate for us to work. So we are covering about 70% of the total amount of deportations in these 5 cities, which it's a big number. And we are trying to identify if it is possible to open another one in Ciudad Juárez, because Ciudad Juárez is becoming again a crossing point especially for the Central American migrants. And that's another thing I want to talk about. As I mentioned before, these modules provide exactly the same services as the Ventanillas de Salud and the mobile health units. The differences are that we have a physician in there, we have psychologists in there, and also we are providing registration to the Seguro Popular, which is just before to change the name and probably the conditions to get access to this insurance, but we are expecting that everything's gonna be the same. And they have 3 months coverage at the very beginning. And they only need their deportation letter saying that they were just deported, and they have access to this health insurance. And the other difference is that the personnel from the modules are going to visit the shelters, mainly in Tijuana and Matamoros. So, and at some point, the people from Matamoros report to us that, you know what, we should stop going to the shelters because there is nobody in there. Like, how is that possible? Nobody? Well, nobody from Mexico. They are full of people from Central America. So we let them know that let's go, let's provide our services to this population. But right now, I just received an email from Nogales saying that one of the largest shelters in there, it's now full of Mexicans again. So it's a very moving back and forward situation, so we don't know what's gonna happen next day. So we're trying to be, at least to be aware of all these changes and try to react in consequence. So now the dynamic of the migration in the US-Mexico border is more complex than before. 10 years ago, we have identified that some people from Central America, especially from Guatemala, were crossing through Sonora, through Altar, in the middle of the desert. So a few people, but basically we only identify Mexican migrants trying to get into the US. And right now, we are struggling identifying Mexican migrants in the border because I mentioned that at the very beginning of my presentation. Now the CBP, the Customs and Border Protection, and Department of Homeland Security are detaining more people, non-Mexican people in the border than Mexican nationals. So that's give us a good idea of what's happening there in the US-Mexico border. And also, the Mexicans used to cross for any point at the border. They have 2,000 kilometers to choose where they decide to cross. Now, the Central American migrants are going through specific large cities. We don't know the reason yet. We are assuming that That's because they are trying to cross to the U.S. into a port of entry to ask for the asylum. So that's that's like the evidence is showing to us. I had the opportunity to be at the shelter in Tijuana, this horrendous shelter in Tijuana. I'm pretty sure you saw the pictures of that, where all these people from the caravans were received in Tijuana. I was there the day they tried to cross to the U.S., and the U.S. Welcomed them with tear gas and rubber bullets. And so the conditions of that shelter was really, really depressing. But at some point, I should recognize that the Mexican authorities were trying to provide some kind of services to help this population. So based on the experience of these migrants from Central America, we already know that the caravans were formed in the Guatemala-Mexico border cities, mainly in San Marcos and Tecunuman. Not San Marcos, that's not the name of the city. Anyway, it's next to Tapachula in Mexico. And then they cross the border through Tapachula, and they walk all the way. You can see right here in Veracruz. They went there because that's how the railroads goes. So they were following the railroads. That's the traditional way for this migration. So they follow that the tracks, and they arrive to Mexico City, where they split into 3 large groups. The most adventurous, they decide to go through Tijuana, and the other 2 groups decide to go to Ciudad Juárez, El Paso, and the other group decided to go to Tamaulipas, Nuevo Laredo. That was the main point of cross, because a lot of people decide to go to Eagle Pass in Texas. It's a very small town. The Mexican city on the other side is Piedras Negras, which is larger than Eagle Pass. But the largest group was in Nuevo Laredo. So the good thing about this is that the Mexican government could at least identify where they were and try to provide as much services as they could. What we identify, that they face a lot of risks during their trip. The weather, especially for those crossing through the Sonora Desert. It's a very complicated trip, especially because they were traveling in some old buses with no air conditioner and very bad conditions. So the government identified all these risks, that it's a very complicated situation, especially for children, pregnant women, elderly, people with disabilities. That a lot of people with these characteristics were included in those large groups. So it was a very, very impressive thing to witness. A lot of addictions. That's another thing that we identified in these groups. A lot of people using drugs, mainly injectable drugs. So it was an internal issue for these groups. And this is what has been identified as health harms for these specific populations. I'm not expecting that you read all this, but one of the main things they registered was injuries related to the walk or related to accidents. For example, many people in Mexico had a really bad reaction to these people walking through the roads, and they just take their cars over these people. In some cases, they just hit them. In other cases, they kill them. So it was a very, very sad situation, but also all these environmental conditions and also vector-borne diseases. In many cases, the health authorities were concerned about how these people could be traveling with some mosquitoes and then create an outbreak of malaria or dengue or chikungunya or another vector disease. Fortunately, nothing of this happened. What I know it happened, it was a lot of chickenpox cases. So that was the main reason why the Mexican authorities decided to start doing immunization to this population, and then they decided to provide the Cartilla de Salud. It's a booklet where they register all the services you're receiving, your immunizations, your visits to the pediatrician for children, or the OB for the pregnant ladies. So this is the way the Mexican government implemented this, the response to this situation. The most important thing is, I will say that in a very long time, and maybe I know the director for the Ciudad Juárez shelter is present here, and nice to meet you. And I know that at least in Tijuana, it was the very first time that the government went to ask for help to the people of these shelters, because they knew that they could not do it by themselves. And the shelters, they are very well organized. They have a lot of support. They have a lot of volunteers. They know how to work with this population. These are the main components of the health response to this situation. I just want to emphasize the number 9, mental health. The people working for the Ministry of Health identify a lot of people with a lot of mental health struggles. They were facing a lot of worries about what's going to happen with my family I left behind, or they were separated at some point and they were very concerned about the condition of their families, etc. So this is the model the Ministry of Health implemented as an answer to this contingency. It's a very complicated one, but it's involved. The thing I believe is impressive is they put to work together the Ministry of Education, Health, the Army, the Navy, the migration authorities, even the telephone company, even it's a private one, they were working together to provide like mobile phones for these populations to get connected with their families back in their countries. And another good thing about this is they decide to work in a very jointly way in all the government levels, local level, state level, and national level. The operative workers, staff from the local levels were doing the services to this population, but also mobile units from Mexico City drove all the way from Mexico City to Tijuana, because those are like hospitals on wheels, so they can be providing more than just a medical consultation. They were providing like some other kind of services. So, okay. So I was listening when I was before my presentation that how complicated it's been this situation, and I agree. We at the U.S. Mexico border the U.S. Mexico border, not health commission, that's institution, just the border. We are facing a lot of problems related to health. We have one of the most polluted cities in the country, Mexicali. It's in a very bad conditions. We have a lot of violence. We have one of the highest rates of HIV transmission. We have the highest rates of drug use in Mexico. So we have a lot of issues in the border. And we are receiving a lot of people in a very vulnerable conditions. So it's a very concerning situation. I believe that right now the response from the Mexican government has been very rapid and very pertinent. Fortunately, these caravans stopped. They are not coming in those large numbers anymore. So probably that's going to be improving the response from the Mexican government. And also they are working in a very collaborative way. I know the International Red Cross Committee is involved, working with the Mexican government. Also, Médicos Sin Fronteras. What's the name in English? Thank you. Oh, you speak Spanish, and I'm here trying to speak in English. No, it's okay. So right now, I believe the Mexican government has a very, very important duty to provide services of quality to this population, to identify the best way to, I don't want to use the word control, I want to manage this amount of people coming to the border. Right now, the Mexican government has been called the wall that Trump promised for the U.S., which is really sad to say because at the end it looks like Mexico is paying for the wall. So I don't know. I just want to finish saying that I believe there is a lot of there are a lot of opportunities to improve the services for these populations, and I believe that as we work here in the U.S. with the Ventanillas de Salud in a very collaborative way, we put these programs together and they are working really well. We should be doing the same thing in the Mexico-Guatemala border, just to try to improve the conditions of these populations. Thank you.
It up to questions.
I could do without microphone.
Okay, you can get started.
Oh, sorry.
Excuse me. Just
Dr. Gonzalez, thank you. I was very happy that you mentioned Ventanillas de Salud. I used to work for Ventanillas de Salud here in Boston.
Okay.
I'm a physician, and we were able to re-inaugurate the Ventanillas de Salud in the year 2015-2016, and it was interesting. And coming to the point you mentioned that this is nothing new. Migration coming in and out is nothing new, but the reasons, the drivers for migration are not new, but the way we are addressing them are acting as if they were new. So in the immediacy interest of helping, we have unintended consequences. So I had the privilege of working for the Ventanilla de Salud for 2 years, and I was able to see all of those physical barriers, and through the training for the Ventanillas de Salud, we were able to create referral systems. And for that, we couldn't just ask questions and then just give something. Yes, I do. So I'm pressured into a question. What I wanted to ask is, in this model, considering this new change in patterns of migration, will the Ventanilla de Salud adapt to all of the issues that migrants from Mexico that are moving to the United States are experiencing in terms of delivering services at the Ventanillas de Salud?
I will say that the model is the same because the barriers are exactly the same. The interesting thing right now is, for example, I was reading a report from the Migration Policy Institute. They are saying in this report that the Mexican migrants are having a kind of new profile, more educated, higher income, so probably, and if I remember well, I'm sorry you are recording, but I believe that was the reason they decided to close the Ventanilla de Salud here in Boston, because of the profile of the Mexican migrants. It's more like related to population who actually has access to health insurance, to health care, and they are not facing these similar barriers as other sectors of these groups. But I believe that any program, it wants to keep succeeding, it should be adapting themselves to the new patterns of migration. It's hard because, as you know, there is not that much money for this program. The fiscal agencies are doing like miracles with they have, but I believe it's a good opportunity for us to think about that. But I will say that right now the model is working for the underserved, the undercover, the most vulnerable population, still working. But yes, we should be adapting for this new profile of the Mexican migrants.
Thank you, Dr. Gonzalez. My name is Beatriz, and I'm an undergraduate here at Harvard. And I wanted to ask you more about who is providing the mental health in these centers and what type of treatment is given to these families.
Okay. In the case of Ventanillas de Salud and mobile units here in the U.S., we are just identifying signs and symptoms of mental health issues. And if we identify some of those, we refer people to a clinic facility to get treatment or to be treated for psychiatrist or psychologist. In the case of the modules for deported Mexicans and the Mexican side of the border, we have psychologists in there, so they are doing the identification of signs and symptoms, and they are doing also therapy in there. And if needed, they are referring people to the mental health hospitals in the cities they are right now. And also the Ventanillas de Salud and the mobile health units has been trained in MH-GAP, Mental Health Gap, this program from the PAHO and the World Health Organization. So if you're familiar with that program, the idea is just to provide very basic training to identify some signs of depression, anxiety, or suicidal thoughts. So it's just to identify and then refer. In our case in Phoenix, I can say that we receive money to do a pilot, to have an iPad connected to someone in Mexico from the mental health hospital, and they ready to hear from us saying, you know what, we identified somebody that really wants to talk to you. They cannot be doing any treatment or any recommendation for medication because they are in Mexico. They are not allowed to practice here in the US. So it was more like counseling, more like a talk, just, in Spanish. In Spanish. And for people in the US, knowing that they are talking with somebody in Mexico, it's a very rewarding thing because they feel like somebody is understanding them. Because for some reason, they believe that we as Mexicans come to the US, they just became different people, and we are the same, but they feel more comfortable talking with somebody in Mexico for some reason. It worked well. The only challenge was the scheduling, because we try to provide our services, if needed, from 10 p.m. to midnight, because that's the time where all the workers are going out from work, and the people in Mexico, they are not working at that time. So that was a challenge, but at the end, we learned that what is being done here in the mobile units and the Ventanilla de Salud is working, apparently. Yeah.
Time for one more question.
Thank you, Mr. Gonzalez. Also, piggybacking kind of off of Beatrice's question, you mentioned that in the Mexican society, it's not really normalized to go to like things like the hospital or checkups or things such as that, and I kind of I can identify a lot with that, because growing up in a Mexican household, it was like, oh, if you get cut, or just like boo-boo or vapor rub or cough drops, things like that. You don't really see people go to the hospital for things that you may need to go to the hospital for. So my question to you is, what do you think we could do as a society and as an organization to help normalize that a lot more?
Educating people, explaining them why it's important to see a doctor. In many cases, we believe that last time I get this, I don't know, this ointment, and I'm gonna keep it using it as much as I can. And I believe that education is the most important tool we should be using, explaining people why it's important to go to see a doctor, if not every 6 months, at least once in a year, to do a complete labs and whole checkup just to ensure. And if you have some diabetes history in your family, you should check up at least every 6 months to be sure everything is fine. And also this whole idea of it's better if I don't know. I don't know. I don't understand that logic, because if you don't know, you're not gonna be treated, and then you're gonna get, your sick is gonna be sicker and sicker and sicker, and that's not the point. But for some people, that's the answer we receive from people when we are inviting them to get screened in the mobile unit. They say, no, I don't want to know. So our job there is to explain why it's important. So education, I will say education, it's the best tool. Yeah. Thank you. Okay. Thank you.